Hi folks, John Adamson, the Rehab and Documentation Guru, getting home after a day of home health and going to be doing some more paperwork a little bit later on. But today I wanted to talk about being careful about what you document. And I've done a previous video on this, and let me lay the background on this. So I used to write a lot of appeal letters for denials related to cases in which the patient received both therapy services and nursing. And sometimes comprehensive nursing assessments state things that undermine therapy necessity. To give you a case in point, a lot of the letters that I wrote were related to denials because nursing had stated in no uncertain terms that the patient was safe and effective in performing either mobility tasks or ADL tasks. And then PT and OT would get involved in the patient and say, well, we see these problems, therefore we're going to treat them according to this frequency and duration. And Medicare would come in behind us and say, hold on, wait a minute. Your nurse has just said that this patient is safe and effective in this area. Therefore, no therapy is necessary. So today I had a situation where a nurse had done a case opening on a patient and noted in her charting that the patient had safely ambulated through the home, including doing a full set of stairs. So when I was going out, I was thinking, one, I hope that's truly the case, and in which case I would determine the patient only needed a PT eval and I would be done. But the patient clearly had a lot of deficits. One, they had a 12 out of 28 Tonetti score. Secondly, they were sub-maximal or sub-optimal on their 30-second chair rise. Also, they had some significant somatosensory issues in their lower extremities, and coupled with a little bit of vestibular visual interplay issues and certainly motor response. Also, the patient has a pelvic fracture with limited weight bearing on one leg and painful when she tries to step on that. Also, the patient demonstrated some lack of judgment in trying to use a cane when really a cane was not a safe device for her. So when we say things like patient noted to be safely ambulating through their home, yada, 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 we may be undermining the patient's ability to receive therapy services. So I pointed this out to the nurse, and I pointed out in my documentation that while on start of care, the patient was safely ambulating, which I highly doubt. These tests reveal, 1, high fall risk, 2, why she's not safe. And I gave the details around that to justify the medical necessity because it was clear that the nursing assessment missed it. So where does that leave us and what should we be doing? If you are the first one in on a case, which doesn't always happen, oftentimes it is nursing, but if you're the first one in the case, make sure that you're making judgment calls on just the area of expertise that you have related to a functional category. Like, I would not comment 100% that a patient is safely taking their medication because that is not my scope of practice. I would not be so bold as to say that all of the patient's ADLs and IADLs were safe or that they were doing them optimally, because that's OT's area of expertise, not mine. So therefore, it's enough to say observationally this was seen and just be objective. Patient performed steps with railing, with cane, yada, yada, yada. Patient ambulating this distance with cane, with observation, and just keep it very objective. Don't make these clarification statements like safely, because you may be undermining the scope of practice of another discipline that needs to go in and see from their eyes, their perspective, their clinical skills, if the patient really needs services, and then let them make the judgment. And this brings up the issue of saying things that are quantifying an activity versus describing the quality. So quantity and quality are very different things. And so I can say probably quantity-wise, a patient is doing this, that, and the other thing, but I, as a PT, should be focusing on mobility when I'm making quality statements. And anyway, it's just a documentation tip. Let's make sure we don't undermine the medical necessity of another scope of practice in what we're saying. Privately, off the record, we might say to the other scope, hey, I'm seeing this, that, and the other thing. You might want to look at this, and that's fine. And then let that expert in their particular scope of practice take it from there. Anyway, John Adamson, the Rehab and Documentation Guru. Hoping you're having a great day. Take care and God bless.